Assalamu alaikum wa rahmatullahi wa barakatuh, guys. Welcome to the channel. Welcome back to the channel of summary of standard medical textbooks. That is nothing but standard medical notes. So yesterday we have learned about the definition, the physiology and causes of respiratory failure. Today we will learn about clinical manifestation and possible investigations of respiratory, how to investigate a case of respiratory failure. So let's begin with the name of Allah. So first of all, what are the clinical manifestations? So what are the manifestations of acute respiratory? We can divide it into acute manifestations in acute respiratory failure and manifestations in chronic respiratory failure. In acute respiratory failure, symptoms mainly dyspnea. Any patient coming with respiratory failure will have dyspnea, uncomfortable awareness of one's own breathing. It is a uniform finding, and other symptoms depends on the cause which is causing the dyspnea. Okay, symptom is dyspnea. Patient will come with breathlessness. So what are the signs? There will be signs of hypoxia, and if it progresses, then there will be signs of hypercapnia as well. What are the signs of acute hypoxia? If there is severe hypoxia, then there can be cyanosis, tachycardia, tachypnea, and if the patient is progressing to hypercapnic acute respiratory failure, then the patient can have headache and altered mental status. The mental status will alter. That is the clue that the patient will be going into hypercapnic respiratory failure. In more advanced states, use of accessory respiratory muscles and paradoxical movements of the chest wall and abdomen. What is paradoxical movement of chest wall and abdomen? Okay, that is called as chest paradox and abdominal paradox if they are separate. Chest paradox and abdominal paradox. So during inspiration, chest will move inwards. Actually that should move outwards, but the chest will move inwards, and during expiration the chest will move outwards. So that is chest paradox. What is abdominal paradox? So during inspiration, abdominal will move inwards, and during expiration, abdominal will move outwards. That is abdominal paradox. So that is seen in impending collapse of respiratory system. Okay, that is a very bad sign which we see in the cases of acute respiratory failure. So paradoxical abdominal indrawing on inspiration. So abdominal should distend on inspiration, but what is happening? Abdomen is indrawing. Abdomen is going inwards during inspiration. So that suggests respiratory collapse is imminent. That is a very bad sign actually which we see. Okay, untreated, if the patient is untreated in this condition, acute respiratory failure can be fatal. Remember, this chest wall paradox can also be seen in flail chest injury. What is flail chest injury? Minimum fracture of 4 ribs at both sides. So what happens is, during inspiration, this part of the chest where there are fractures of the ribs, this will move inwards during inspiration, opposite to the chest movement, and this will move outwards when the chest moves inwards during expiration. So that is chest paradox seen in flail chest injury. Okay, and in diaphragmatic paralysis, phrenic nerve palsy. So what happens is, diaphragm actually in inspiration moves downwards, and in expiration it moves inwards, but it happens, it will be opposite in diaphragmatic paralysis. What happens is, diaphragm will move inwards during expiration and it will move outwards during inspiration. So that is abdominal paradox, and you will see this one, abdominal indrawing due to, that is because of diaphragmatic paralysis only. Okay, so you can see this paradoxical movements of chest and abdomen, failed chest injury and diaphragmatic paralysis respectively also, and this is a very bad sign. Okay, that indicates imminent or impending respiratory collapse. Moving forwards, so chronic respiratory failure develops progressively, and it is usually punctuated by acute exacerbations. So here there will be breathlessness. Again, there will be a spike due to some infection, some reason. Again, if you treat, it will go like this. Again, there will be a spike due to some reason. Again, it will go like this. So this is known as, this is exacerbation, and this is the normal breathlessness at rest. Okay, so Chronic respiratory failure develops progressively and is usually punctuated by acute exacerbation that may or may not be fully reversible. What are the symptoms? Dyspnea on exertion or at rest if it is severe, with reduced exercise tolerance, and somnolence and headache is seen in patients with hypercapnia. Pathological somnolence, excessive sleepiness is seen in patients with hypercapnia. And along with that, symptoms of underlying conditions. What are the signs? There will be signs of hypoxemia. What are those? Tachypnea, tachycardia, cyanosis, and these you will see only in chronic respiratory failure, that is clubbing and hypertrophic osteoarthropathy, along with symptoms of right ventricular failure. What are the signs of right ventricular failure? There will be pulmonary hypertension. Okay, there will be raised JVP. There will be raised JVP. There will be what do you call hepatomegaly. Hepatomegaly. There will be, I will like signs of right ventricular failure all. So there will be raised GVP, there will be congestive hepatomegaly, tender hepatomegaly, congestive hepatomegaly, there will be pedal edema, bilateral pedal edema. Sometimes you can hear triple murmur if you auscultate, and you can have right ventricular heave, ventricular heave on palpation when you palpate the chest. So these are the signs which you see when there is right ventricular failure. Okay, ejection systolic murmur you can see in pulmonary area. So these are the signs of hypoxia. Then signs and in chronic cases, this is the differentiating feature: signs of right ventricular failure, and there will be signs of carbon dioxide retention. What initial signs before going on to changes in the mental state? So you will have bounding pulses. This is because of increased carbon dioxide levels in the body, and because of vasodilation. This causes vasodilation. No, so because of vasodilation, there will be increased pulse pressure. Because of increased pulse pressure, there will be bounding pulses, and flapping tremor will be there. Asterixis. This is also known as asterixis. What is asterixis? Just say the patient to extend the hands forward and just press the palms like this. Then you will see flapping like this. So that is nothing but asterixis of flapping tremors. So you will see these signs of carbon dioxide retention before going on to changes in the mental status, that is in severe cases. So signs of hypoxemia, okay, in the differentiating phases of clubbing, and signs of signs of carbon dioxide retention, and also these are all this differentiating feature. Increased accessory respiratory muscle use, the sternocleidomastoid and mastoid scalene muscles, they will also be they will be standing, they will be prominent in these patients. Increased antero-posterior diameter of the chest and flattening of the diaphragm of the chest, especially in COPD patients. And conjunctival injection and skin erythema, again because of carbon dioxide vasodilatation. So, and signs of the underlying condition. So you can, in eyes you can see conjunctival injection is nothing but redness of the eyes, and skin erythema, redness of the skin. Chest will be barrel shaped chest in cases of COPD, and bounding pulses, asterixis, clubbing, hypertrophic osteoarthropathy, and changes of right ventricular failure. These are all things which you see in cases of right ventricular failure. Okay. Moving on forwards. So what happens in acute on respiratory? Now in chronic respiratory failure, there will be compensated. Body will compensate for that. But when there is, you give some extra load for that, that will become decompensated. So initially there will be respiratory distress. Initially there will be dyspnea, followed immediately by drowsiness, and patient will eventually go into coma. So there will be change in mental status. Okay. And you can also see if the patient does not have any findings of RVF when there was compensated state. You can see in the decompensated state signs of right ventricular failure, that is peripheral edema, raised JVP, hepatomegaly, ascites. These all you can see in cases of acute exacerbations of chronic respiratory failure. Moving forwards. So this is a summary of signs and symptoms. Okay. So these are the signs of dyspnea. Respiratory rate is more than 25 per minute or less than 8 minutes. Tachycardia, bradycardia in severe cases, arrhythmia in severe cases. You can have bradycardia and arrhythmia in severe cases. Remember this point. Early cases you will have tachycardia. Again, this less than 8 per minute, you will, in severe cases you will have decreased. So bradypnea and bradycardia, arrhythmia you can see in severe cases. Inability to speak in full sentences, that is sign of dyspnea. Cyanosis, severe cases. Sweating, severe cases. obstructed airway or stridor, when you will see when there is upper airway obstruction, larynx or trachea is involved and there is obstruction to that, then the stridor is a very bad sign, and you should proceed to bronchoscopy very early. And if there is no time, you can do cricothyrotomy, something called as one procedure, to gain some time. And so cyanosis will be there, sweating will be there. Most importantly, you just observe this one: the patient will not be able to speak in full sentences. Okay. And if there is substituted area, there is stridor. Use of accessory muscles will be there. Intercostal recession will be there. Pulsus paradoxus will be there. What is pulsus paradoxus? Normally during inspiration, BP falls by less than 10 mmHg. Okay, less than 10 mmHg. But this fall will be increased more than 10 mmHg when there is respiratory failure. That is nothing but pulsus paradoxus. There will be restlessness and agitation. That is nothing but altering in the mental status. So this will happen when the patient is going from hypoxemic state to hypercapnic state. Asynchronous respiration. This is sign of impending respiratory failure. Inability to lie flat. That is nothing but orthopnea seen in severe cases of dyspnea. Okay. So these are the signs when you see in cases of respiratory. What are the indicators of hypercapnia? Bounding pulse, warm peripheries, asterixis, somnolence, lethargy, tiredness, okay, weakness, confusion, decreased consciousness, headache, especially morning headache. Morning headache in cases of chronic respiratory failure. Why morning headache? Why morning headache? Because when the patient sleeps, furthermore the respiratory drive will fall. So during the night time, during the sleep time, carbon dioxide will accumulate further. So that will cause headache. That will cause cerebral vasodilation, and morning headaches in patient with chronic respiratory failure. So these are summary of signs and symptoms of respiratory failure. Coming to investigations and diagnosis, I said in the beginning only, it is a very lengthy topic. It will take some time, but if someone learns, then it is very helpful. In acute respiratory failure or in cases of acute on chronic respiratory failure, both conditions, acute respiratory failure or acute on chronic respiratory failure, meaning acute exacerbation of respiratory failure, chronic failure. Take history, do the examination. This should be done fastly, okay, because it is an acute case. Okay, and remember, acute hypercapnic respiratory failure is an emergency. And three most common conditions which it is seen is: number one is upper airway obstruction, upper airway complete obstruction. One. Two is severe acute asthma, acute severe asthma. Third one is exacerbation of COPD. So in these cases, these three are the commonest examples for acute hypercapnic respiratory failure, and you should intervene very fast. In upper airway obstruction, you will have stridor, so remove that foreign body, or if you don't have time, you do cricothyrotomy. Severe acute asthma and exacerbation, you give bronchodilators, okay, and you give steroids and magnesium sulfate in severe cases also, okay. So first take history, do examination fast, and look signs of severe hypoxemia. What are the signs? What is the one thing you remember? Unable to talk in full sentence or cyanosis, that is a sign of severe hypoxemia. And also look for signs of hypercapnia. Why is this important? This is important. Which type of respiratory support is required for the patient? So you need to see this immediately. You have to act now. So you should see all this. So in order to give a proper respiratory support, proper respiratory stabilization. So hypercapnia, there will be altered mental status. So after seeing this, you will give some respiratory support, maybe in the form of some respiratory mask or Venturi mask or HFNC or BiPAP, CPAP or intubation. Okay. So usually this BiPAP or intubation is done when the patient has altered mental status, or HFNC, or you can also try. But if HFNC fails, you can go to BiPAP and intubation. But in cases when there is only hypoxemia, just by giving high pressure, high oxygen saturation by non-breathing masks, okay, or oxy masks, you can stabilize the patient. So this you will do. You will observe the patient whether there is a sign of hypoxemia and sign of hypercapnia, whether the patient's mental status is altering or not, and immediately you will perform the three key questions, these three: chest X-ray, ECG after stabilization of the patient, and ABG will you can do at that time only. ABG ideally, if not possible, VBG you can do. Okay, pulse oximetry to know if there is it will confirm hypoxemia. If it is there or not, pulse oximetry will confirm hypoxemia. But ABG is superior than that. You have to do ABG also. Okay, so you will give immediate appropriate pulmonary support, and you will do these three investigations: chest X-ray, ECG, and ABG, RTL blood glasses. Along with that, you will send some investigations to rule out causes of respiratory failure. So what are those investigations? We will send CBC, complete blood count. If there is anemia, which is contributes to tissue hypoxia. Okay, if there is anemia, that can contribute to tissue hypoxia. And one point important is polycythemia. If it is there, hemoglobin is raised, is what do you call, hematocrit is more than 55% in males. Okay, if there is polycythemia, then it is indicative of chronic hypoxemia or chronic respiratory failure. And if WBC count is raised, then it suggests acute infection. Okay, you will see hemoglobin, you will see mainly WBC count. You will do coagulation screen. Altered if there is DIC in severe cases, disseminated intravascular coagulation, when there is severe, like in COVID-19 patients, severe COVID-19 patients which were admitted in ICU, okay, in pandemic. So they were having DIC, no? So we were ordering ferritin levels, 5-year nogen levels, and coagulation profiles for what purpose? For this purpose only, to see whether there is DIC and if whether the patient is deteriorating or not, whether anticoagulants are required or not. So coagulation screen you will do in severe cases. Okay, this is done in severe cases. Okay, we'll do CBC, then electrolytes will send RFT, LFT, C-reactive protein you will do. So what this will tell, this will guide to associated complications because of any due to respiratory cause. If liver is going into failure or renal is going into failure, those all things. Underlying causes you will know. Premorbid conditions, whether the patient is having any coexistent comorbid conditions, you will know. Phosphate and magnesium, low levels will aggravate respiratory failure. Also potassium, one more is potassium. So decreased potassium, magnesium, phosphate will aggravate the respiratory failure. They can even cause respiratory failure. They may be cause of respiratory failure. Okay, okay. Serum amylase and lipase in patient suspected with acute pancreatitis, because pancreatitis is a cause of ARDS, and ARDS will cause respiratory failure. Thyroid function tests you will order. Why? Because hypothyroidism is a cause of hypoventilation, alveolar hypoventilation, and that will cause type 2 respiratory failure, hypercapnic respiratory failure. That's why you will order thyroid function tests. Hypothyroidism, okay, hypothyroidism is a rare cause of hypoventilation. And you will order creatine kinase troponin I. Why? You will see whether there is MI also, and if there is high creatine kinase with a normal troponin, that will indicate myositis, means muscle disorder. So some muscle disorder is causing respiratory failure. So creatine kinase, if creatine kinase is raised without raising of troponin levels, that means there is some muscle inflammation is going on. Okay, so again one more investigation is NT-proBNP. NT-proBNP, this will say this is to exclude cardiac causes of pulmonary edema. Cardiac pulmonary edema, NT-proBNP will order. So in brief, CBC will do RFT, LFT, electrolytes. Okay, electrolytes will do magnesium, phosphate. Okay, and if you are suspecting pancreatitis, then serum lipase or amylase. Okay, and TFT, thyroid function test you will do. And cardiac cause you shouldn't forget in respiratory failure. No? Pulmonary edema is a very important cause. So tropi you will do, tropi, and NT-proBNP, and if you are suspecting some myositis, then you can send for creatine kinase. Okay, so these are the investigations you send. Now how you will proceed in cases of a patient present. So any acute respiratory failure patient presents with breathlessness. So the causes, so you will proceed as breathlessness. How you were proceeding in cases of acute breathlessness, similarly you will proceed in case of acute respiratory failure. How you will proceed? First you will exclude upper airway obstruction. The sign will be stridor will be there. Stridor is a inspiratory sound, wheeze is an expiratory sound. Okay, stridor because of some foreign body or laryngeal edema or laryngeal carcinoma or vocal cord paralysis. Okay, so this first thing you will rule out. Okay, first thing upper airway obstruction. Second thing anaphylaxis you will rule out. Third thing tension pneumothorax, sudden onset of breathlessness along with one-sided chest pain. Okay, that you should rule out. Okay, in this there will be hyperresonant unilateral hyperresonant silent hemithorax. Okay, and these are how you will proceed after excluding these three. Now you will exclude cardiac causes of breathlessness. What are the most most important acute cause of cardiac causes? Those are pulmonary edema, acute pulmonary edema, and acute massive pulmonary embolism. So these things we have discussed in acute breathlessness. So you can go and watch that video. Okay, and what are the respiratory causes of acute cause of breathlessness? Acute severe asthma and acute exacerbation of COPD. In this manner you will proceed. In this manner, first you will rule out these two, then you will go to asthma and COPD, then you will think of pneumonia. And if not, in the now cardiac is gone. Okay, you will get to respiratory, cardiovascular. Okay, then respiratory, then you come to metabolic causes, then you will go to psychogenic causes. I am not explaining this because I have explained this in the topic of breathlessness. Okay, so metabolic acidosis due to diabetes or renal disease or some poisoning, or psychogenic ventilation like panic attacks. Okay, so this is how you will proceed in acute respiratory failure. And you should also see the severity of gauge the severity of acute respiratory failure. How you will gauge? SpO2, simple SpO2. If it is between 90 to 95, it is mild. 85 to 89, it is moderate. Less than 85, it is severe. Or PaO2, 60 to 82, mild. 40 to 60, moderate. Less than 40 is severe. One more thing is S by F ratio. What is S? S by F ratio? S is nothing but SaSO2 by FiO2 ratio. Okay, so in ARDS we calculate PaO2 by FiO2. So this replacement of PaO2 to SaO2 is known as Kigali's modification. Kigali's modification. Okay, to rule out acute respiratory distress syndrome in any patient where the facilities are limited, you can use this one, S by F ratio. What is FiO2 we will know, and FiO2 differs depends upon by which delivery devices you are giving oxygen. Okay, so if this S by F ratio is more than 315, ARDS is excluded. Okay, and you will say that the dyspnea is mild. If it is less than 315, that is moderate. If it is less than 235, then it is severe. And you should remember, in mild cases you will start with oxygen therapy if there are no signs of hypercapnia. Normal oxygen therapy. In case of COPD, you will see Venturi mask. In moderate to severe cases, you will think of non-invasive mechanical ventilation. Either it can be non-invasive or invasive. Okay, so severity is also important, and along with severity, signs of hypoxemia and hypercapnia are also important for deciding which respiratory support we should give, along with history and examination. In chronic respiratory failure, you will have time. Okay, so you can proceed step by step. Take a history and examination in a patient with dyspnea on exertion they will have. Okay, one can proceed with investigation step by step as shown in the flow chart. So first you will do a walking oximetry. So why walking oximetry? Patient will come and he will sit, his saturation will be normal, but in patient with chronic respiratory failure, you should take a walking oximetry so as to rule out chronic respiratory failure which the patient is having when he is having some exertion. Okay, walking oximetry, you will have walking oximetry. And PEF, peak flow assessment, peak flow expiratory flow meter. In asthma you will use this to gauge the severity of asthma. So by this you will know whether the patient is having chronic respiratory failure or not. If the walking If the patient is walking and saturation is falling, that means the patient is having uh, uh, chronic respiratory failure. Okay, now if at this point only you have diagnosis, then you will go to first line investigations, which include chest X-ray, ECG, spirometry, and also ABG also you consider here. ABG, these are the first line investigation: chest X-ray, ECG, ABG. Okay, and spirometry will do. Spirometry will reveal whether it is an obstructive lung disorder or restrictive lung disorder, obstructive or restrictive, and also it will help in gauging severity. Along with those, as we have discussed before, the investigations, so you will do CBC and basic metabolic panel, which we have discussed in the just now in the table. Okay, now after this also, if you don't have any diagnosis, you will proceed for the second line investigations. Those are chest CT, HRCT thorax, and one more thing is angiography, pulmonary angiography, to rule out any pulmonary arterial hypertension due to chronic thromboembolism. Okay, you will do lung volumes and diffusion lung capacity of the lungs, and if you are suspecting any neuromuscular disorder, neuromuscular function, and if you are still suspecting cardiac cause, 2D echo you can do. Okay, HRCT you will do, pulmonary function test, PFTs you will do, 2D echo you will do, and TMT, treadmill test, or stress test you will do. Okay, these are all the second line investigations. After this also you are not getting any result, then you can go for consider cardiopulmonary exercise testing. In the these all except to HRCT, up to this a primary care worker can do the investigations. After this, all investigations are done by specialists. Okay.